Good.
Okay, so today we're going to be talking a little bit about ankle sprains. So the first thing we're going to do is define ankle sprains and then talk about some of the long-term consequences that could be associated with them. Then we're going to talk about a study that we did here at Weber, looking at the relationship between performance on some functional tests and ankle sprain injury occurrence. And the last thing we're going to do is talk about some ankle sprain / chronic ankle instability prevention strategies. So lateral ankle sprain is going to be an injury to any of the lateral ligaments of the ankle. So as you can see here, this one right in front is going to be your anterior talofibular ligament, and then you have your calcaneofibular ligament, and then your posterior talofibular ligament. So the most common mechanism of injury for a lateral ankle sprain is going to be an inversion mechanism. So that's going to be when your ankle rolls out like this. So that's most commonly going to happen in the plantar flex position because that's more open packed, right? So they're going to be like this and that's going to roll out. But if they're dorsiflex, they're going to be locked down. So it's a lot harder for them to roll out. There's a couple different ways that people are grading ankle sprains. The first way is by the number of ligaments that are injured. So, for example, a grade 1 would be an injury to just the ATF, and then a grade 3 would be an injury to all 3 ligaments. And then the second way is by the amount of injury that actually happened to the ligaments. So a grade 1 would be just a mild tearing, grade 2 would be a more moderate tear, and then a grade 3 would be a complete rupture. So those kind of go back and forth, and different people use different things. So if an athlete tells you, hey, I have a grade 2 ankle sprain, then you may say, okay, is it more you've injured 2 ligaments, or do you have a moderate tear in there? So the normal signs and symptoms are going to be obvious swelling, bruising, lots of range of motion, loss of strength, and a decrease in their balance and proprioception. All right, so the treatment for a lateral ankle sprain, of course, for the first 48 to 72 hours, you're going to be using the Price principles, so protected rest, ice, compression, and elevation. And then once you get that inflammatory process to kind of slow down, you'll move into addressing their strengthening the balance training and proprioception. So ankle sprains are one of the most common injuries among the physically active population. So for example, 23% of all high school and 14% of all collegiate athletic injuries are ankle sprains. So that's a pretty high number. So it's something that we need to be knowledgeable about. Also from 1998 to 2006, over 400,000 members of the military sustained an ankle sprain. So that's a lot of injuries there. What's even more scary about those numbers is up to 75% of the individuals that sustain that initial ankle sprain develop chronic ankle instability. And chronic ankle instability is when someone has an initial ankle sprain and then they continue to get recurrent ankle sprains, as well as having sensations of giving way and residual symptoms such as loss of range of motion and balance deficits. So people with chronic ankle instability can also develop some long-term consequences, such as osteoarthritis and a decrease in their health-related quality of life. And the way that we assess health-related quality of life is by self-reported functional scales. Okay, so the most common one with the ankle is going to be the foot and ankle ability measure, and we use that a lot in our training room as well as research-wise. And someone with chronic ankle instability would score about an 80% or less on the FAM sport, and then a 90% or less on the foot and ankle ability measure that's just activities of daily living. All right, so now we're going to go into the study that we did the last 2 years here at Weber International, and we looked at some baseline measures on balance and functional movements and saw how those were associated with the incidence of ankle sprains. We partnered with the University of North Florida, and then we also partnered with Florida Southern College this last year, so we have some athletes from there as well that are participating. So like I already said, ankle sprains are one of the most common injuries in the physically active population, so we need to find ways to prevent them. So in order to do that, we have to discover what some of the major risk factors are. So the Stark Excursion Balance Test, the BEST test, and the weight-bearing lunge test have been shown to detect the limitations in movement and balance. So we decided that if they performed poorly on those tests, maybe they would sustain an ankle sprain. So we decided to look at the relationship between performance on those tests and ankle sprain occurrence. So the purpose was to determine if there is a relationship between performance on the BEST, the STAR excursion, and the weight-bearing lunge test and ankle sprain injury occurrence. So we ended up with 544 collegiate athletes. There were 164 females and 380 males. The average age was 19.74 plus or minus 1.73 years. Average height was 174.04 plus or minus 9.59 centimeters. And then the average mass was 78.3 plus or minus 27.86. So the nice thing is we had athletes from all kinds of sports. So we had football, men's and women's soccer, men's and women's basketball, baseball, softball, track and field, cross country, and then we even got some lacrosse players from Florida Southern. So we had a large realm of sports that you could injure your ankle in. So for the methods, we had them perform a injury questionnaire. So we pretty much just asked them, have you ever injured your ankle? If you did, was it your right or left? When was that injury? What was the actual injury? And then did you do any treatment for that injury? So most people that have an ankle sprain may, go to treatment for a week or so until it's better, and then they say, okay, I'm better, and they return to play. So that was something that we wanted to know if they did any long-term rehab for. And then we also asked if they had any injuries at the knee or the hip. So then after they finished that, we had them perform the BEST test, the STAR excursion, and the weight-bearing lunge test on both limbs. We countered the order of the test, so they weren't, each athlete wasn't doing the same order of tests, they were randomized. And then we also countered the limbs, so everybody didn't do the right limb first, we had it countered. And then after that, we just followed them until they were either no longer an athlete at the school or we end the study. And we look for their ankle sprain injuries in our injury tracking software. So we said that an ankle sprain injury was an injury to any of the ankle ligaments that required them to miss at least one day of competition at some point. So even if they were just limited in one day of competition, we counted that as an ankle sprain injury. So the first test that we did was the STAR excursion balance test. You have the subject maintain balance on their testing limb, and then they reach into the anterior position, the posterior medial position, and then the posterior lateral position. The trial was repeated if they removed their hands off their hips, they pushed the board or slung it forward instead of just pushing it lightly. They lost balance, they didn't fully return to their start position, or their heel lifted off the planted foot. So this is a picture of a woman doing the STAR excursion. So you can see that her test limb is on this middle plate right here. And if she was pushing forward this plate, this would be the anterior direction. So when you're having them do the anterior direction, you have to make sure that their heel is staying firmly planted. If they start lifting their heel up, they can get some extra range of motion there that'll give them a higher score than they really should have. And then if she was pushing back in this direction, this would be the posterior medial, and then the one that she's actually doing right now is the posterior lateral. So we did 4 practice reps in each direction on one limb, and then they did their 3 trial reps after that to help eliminate a learning curve. So obviously if you're doing any type of balance, when you do it a couple of times you get a little bit better. So we had them do 4 practice trials to make sure they understood how to do everything, and then we did the 3 test trials after that. And everything was measured in centimeters. So we normalized those values to leg length measurements, which we measured from their ASIS to their medial malleolus. The next test is the weight-bearing lunge test. So you have the athlete put their hands up on the wall and then perform a lunge until their knee makes contact with the wall. We had them start around 4 centimeters, and then we moved them back in half centimeter increments until there was a failure. And a failure would be either their knee couldn't touch the wall or their heel came up off the floor. Okay, so this is a way to measure dorsiflexion range of motion, and it's a pretty functional way to measure it. So I really like this test, and I think it could be beneficial to some of you guys to assess dorsiflexion. And the end distance was from the great toe to the wall, and of course measured in centimeters. The last test we did was the balance error scoring system. So you have the subject maintain balance on a single limb with their eyes closed for 20 seconds, and then you count the amount of errors that they have during that time period. So the errors included removing your hands off of your hips, losing balance and tapping down the opposite foot. If you went into greater than 30 degrees of hip abduction or flexion, and then opening your eyes, or remaining out of the testing position for more than 5 seconds. So if they fell out of the testing position, they had to get right back into it within 5 seconds, or that counted as another error. For analysis purposes, for the STAR excursion, we averaged the 3 test trials together for each limb and for each direction. And then for the weight-bearing lunge, we did the same thing. We averaged the 3 trials on each limb. And then we ran the logistic regression analysis to determine if there was a relationship between the performance on the test and ankle sprain injury occurrence. And we set alpha at less than 0.05. So we ended up deciding to exclude anyone that had a previous ankle sprain injury, since ankle sprains are the largest risk factor, or having a previous ankle sprain is the largest risk factor for getting another ankle sprain. So we decided to go ahead and eliminate those people from our analysis. We kept them in the study, but we didn't use it for this analysis. So we ended up having 289 participants that didn't have a history of an ankle sprain. So that's a large number. We had almost 600 subjects, and only 289 of them had never sprained their ankle. That makes you realize how many ankle sprains are actually happening. So 21 of those people ended up sustaining an ankle sprain during the follow-up period. And when we compared the means, we didn't have any significant association between the performance on those tests and the incidence of ankle sprain injury. So here's the results we have here. We have all the measures that we used in each limb, and then the means and the standard deviation for the injured group versus the uninjured group, the odds ratio and the p-value. I'm not going to go over all these numbers, but as you can see, the p-value was never less than 0.05 for any of those, so it wasn't statistically significant. So in conclusion, there was no apparent relationship between the performance on the best STAR excursion, weight-bearing lunge test, and ankle sprain injury occurrence. So obviously we needed to perform additional research to see if there's some other tests that may lead us into some insight into what's causing people to have ankle sprains. There was also another study done by Smith et al., and it was pretty similar to ours. They had about 200 athletes that participated. And they just did the STAR excursion balance test. They had about 80 people that sustained a non-contact injury. They didn't say just ankle sprains, they said non-contact injuries in general. And they found the same as us, where they didn't find a difference between the means of the uninjured group versus the injured group. But they did find that if they had an asymmetry of greater than 4 centimeters on the anterior reach of the STAR excursion, there was a higher incidence of ankle sprains. So that is something that we can look at with our data. And we will do that in the next couple of months and see if we find the same thing. And obviously the thought should be that if the anterior reach is that way, so should the STAR excursion. The STAR excursion and the anterior reach and the weight-bearing lunge should be somewhat associated with each other. All right, so now we're going to talk about some ankle sprain prevention methods that you guys can start using. So the NATA position statement says that you should have at least a 3-month-long prevention program that focuses on balance and neuromuscular control. And then you should also focus on strengthening the ankle inverters, everters, dorsiflexors and plantar flexors, as well as the hip abductors and extensors. And then it also is asking you to assess dorsiflexion range of motion. So some ways to assess dorsiflexion range of motion, we have the first one I already told you about was the weight-bearing lunge test. So that's pretty easy to perform on your athletes and an easy way to see if they have a dorsiflexion deficit. You could also do just supine active and passive dorsiflexion range of motion. And then you can do a squat test to see if you see them kind of going down a little lower on one ankle versus the other. So I prefer the weight-bearing lunge test and the squat test just because they're more functional. So I don't really care if someone's sitting on a table and they can have full dorsiflexion. I care if when they're doing a squat or doing a functional movement, do they still have full dorsiflexion. So there's 2 reasons that you may have a lack of dorsiflexion. So the first one is going to be if these posterior musculature back here, mainly your gastroc and your soleus, are tight. So if this musculature is tight, you can tell how that would inhibit you from going into full dorsiflexion. So that one's pretty easy to fix. Having them stretch on a slant board, doing some towel stretches, maybe some myofascial release, some massage, all that stuff can help loosen that stuff up and give them their full range of motion. The second way is from an arthrokinematic restriction of your talus. So This bone right here is your talus. Hopefully you guys can all see. So an individual that has multiple ankle sprains, when they tear these ligaments, their talus tends to slide forward a little bit, and then it ends up sitting a little more anteriorly. And as it sits more like that, because they're not moving their ankle as much, the structures in the posterior section get tighter. Okay, so those get tight, and then the talus ends up sitting forward more. Okay, so the way to fix that is by doing some joint mobilization techniques. Okay, so in the picture right there, that's an anterior to posterior talar glide that an athletic trainer or physical therapist may perform. We use these a lot at Weber. And then the next thing that you could do is more of a functional mobilization. So you have them, standing up, put some pressure on their talus, and then have them just go into a squat position. So that'll help force their talus to glide posteriorly more properly. All right, so this was a study done by Dr. McKeon and his group. He looked at a balance training protocol to see if it would improve their postural control and function in individuals with chronic ankle instability. So he had about 30 subjects, and he randomly assigned them to either a 4-week balance protocol or a control group. Okay, so the control group did their normal activities for 4 weeks, and then the balance training group did 3 sessions every week for 4 weeks for about 20 minutes. Okay, and these were the exercises that they did. So they did a hop to stabilization, which would be just hopping from one point to another and stabilizing, and then hopping back. And then a hop to stabilization with reach would be hopping and then reaching back with your opposite foot. And then you have an unanticipated hop to stabilization, which is more like a dot drill. So you have dots on the floor that have numbers on them, and you say, okay, hop to number 5, hop to number 3, and they hop as fast as they can. And then a single limb balance progression. So they found that this 4-week balance training protocol significantly improved their self-reported function, static postural control, and dynamic postural control. So that's really important, because not only were they numbers-wise getting better, but they also thought they were getting better. So their self-reported function improved, and that's really important especially when you're dealing with athletes. Okay, so now I'm going to go into what we're doing here at WIU. So we're not necessarily doing ankle prevention, but ankle sprain prevention, but if an individual does sustain an ankle sprain, we have them do a prevention program to help them from developing chronic ankle instability. Okay, so of course this is dependent on if they're willing to keep coming in, week after week and keep doing it. Some of the kids are, some of them aren't. So it seems to be working with the ones that are coming in to do it. So when it comes to strengthening, we're using single leg calf raises. We usually start with straight ahead, and then we'll start the 3 different positions. And then for inversion and eversion, we use band work right off the bat, and then they progress to towel slides, which is pictured here below. So you put the towel on the floor, and then a weight on the side, and have them go into inversion and eversion. And then we're using heel and toe walking for plantar flexion and dorsiflexion. As far as balance training is going, we're using the star excursion balance test, the hop to stabilize, hop and reach, and a single leg balance progression. So for the star excursion balance test, you'll have them stand on their involved limb and then tap into each direction. So they'll tap into the anterior direction, the posterior medial, and posterior lateral direction. We usually have them do about 3 sets of 10 of these. And I really like this exercise because it helps them improve their dynamic balance. So they're not just balancing in a stable position, because that's not what they're going to be doing during athletics, right? They're going to be having to move and change positions. So this helps them balance while they're moving their other body parts. The next one is going to be a hop to stabilize. So this is the grid that we use right up here. So here's the central dot that they start at, and then they can hop to all these surrounding dots. The distances are 18, 27, and 36 inches. So we have them start at that central point, hop to where they're going to hop, and then stabilize for a few seconds and hop back. So they must do 10 reps in each direction before they can progress to the next distance. The next exercise we use is a hop to stabilization and reach. So the grid is the same as the exercise before. So you have them start at that starting position right there, hop to the point they're hopping to, stabilize, and then reach back with their opposite foot and tap down. So again, the distances are 18, 27, and 36 inches, and they must be able to perform 10 in each direction before they progress to the next level of difficulty. Next, we do a single limb balance progression. So we obviously start with eyes open on a stable surface, then move to eyes closed on a stable surface, and then we progress to the unstable surfaces, usually a foam pad, and then an unstable surface with a ball toss. So we usually start them about 20 seconds and then progress to 30 and 45. Once they're able to do 45 seconds with no errors, then they can move to the next difficult exercise. After that, we like to give them a more functional exercise to work on their balance. So for example, if it's a basketball athlete, we may do a single leg squat on a foam pad while they're passing a ball, or a double leg squat on an upside down BOSU ball while they're passing a ball. And then I do the same thing with my volleyball athletes. I'll have them, passing balls, setting balls while they're balancing. Okay, so in conclusion, we talked about the study that we did here, and we found that the performance on the weight bearing lunge test, STAR excursion, and BEST test didn't seem to predict ankle injuries. So right now, performance on those tests doesn't seem to give us insight into who may sustain an ankle sprain. And then I also went over the prevention strategies for ankle sprain injury, including strengthening, dorsiflexion range of motion assessment, and balance training. So here's my contact information if you guys end up having any questions later on. And if you have any questions right now, feel free.
I have a question.
Yeah.
In your in a return to play protocol, do you use any kind of decompression of the joint? So maybe like a banded decompression of the joint through ranges of motion to kind of promote some blood flow in that area, still going through ranges of motion. I've seen different protocols coming through an athletic training program of kind of opening up that joint and still having them, not actively but passively, taking them and moving them through the joint to try to regain some of that range of motion early on. So maybe in the situation with Coach Ayers in the first week or so, regaining that range of motion is optimal to do right now.
Yeah.
Pain-free range of motion,
Yeah.
swelling.
Usually for range of motion purposes, we use ankle circles, the alphabet, that kind of stuff. And then later on, once they're not as sore, we'll move on to the joint lobe techniques. And
Okay.
that's more, so you apply some traction there and then push down. So that really is kind of opening up that joint and then gliding them through their range of motion.
I had a question for the during your study for the lunge test that you did. Was there any corrections for kind of the knee to toe relationship? I just noticed when a lot of athletes will do that mobility technique as well, they'll search inside a lot. They'll try to get the knee inside the toe to get that to the wall.
Yeah. We didn't really notice any problems with that. There was a tape on the floor that they were kind of sliding their foot back from, and they were really just kind of going straight with the tape. So we didn't really have to correct them at all. We noticed a little bit more that they would do that technique when they were doing the STAR excursion.
Okay.
So they'd be bouncing on the STAR excursion, and you could kind of see their knees kind of going wherever they wanted to try to get a little bit more range of motion.
Okay. And then also, what are your thoughts on, your thoughts on ankle taping? Just in general, I guess, and then for the athlete that doesn't, like I've had experiences with coaches that just were mandatory that all their athletes tape, whether they have an issue or not.
If you're going to look at taping versus bracing, bracing seems to work better, especially in individuals that have never sustained an ankle sprain. Taping tends to stretch out over time, and it's not as valuable. We have other athletic trainers here that preventatively tape, so it does work, but I think that braces work better. So we, at least in our training room, if someone sustains an ankle sprain, they'll be taped and braced right after, and then they'll move to just the brace. And that seems to be working for us.
Would you be of the belief that possibly that relying on a taped or braced ankle all the time without the addition of foot strengthening, is that a negative thing, or Is
Well, I
that,
think,
does that come
especially
across?
for our athletes, they're only wearing the braces like during practice or a game. So when they're at weights, they're not wearing their brace. So, you know, they're still strengthening and you're really not in the brace that long.
Mhm.
And plus, a brace is only gonna keep you from going into those extra range of motion. It's not gonna prevent you from doing your normal range of motion. So, you know, as long as it's not preventing you from going into a normal range of motion, you're still gonna be strong in that area.
Okay. And then the last question is, for just how in general everything is like, think like shoulder injuries, stuff like that, we're kind of moving more towards the prehab end to kind of get ahead of some of this stuff.
Mm-hmm.
Would you recommend, you know, I feel like in strength and conditioning, it's kind of a big miss a lot of times is training maybe possibly barefoot or just some of the tests you were doing there as implemented in some of the programming.
Yeah,
Is that
I
something
mean,
you recommend,
yeah,
or?
I think that, you guys can speak for yourselves, but I think that the most of our strength coaches on this campus are doing some of these activities, at least balance training during weights. Especially volleyball wise, I know that our indoor volleyball team does a lot of hopping, to help prevent ankle sprains. But it's hard when you have a large group of individuals and we don't know yet, you know, what's gonna separate. You know, if you're doing ACLs, you know, if you do a box jump, if they perform poorly on that, they should be in this group that's doing prevention stuff. If they perform well, they don't need to do it. But right now, we don't know that with ankle sprains. So we can't really separate into small groups and say, okay, this group needs to be doing extra balance training because we think they might sustain an ankle sprain. We don't know that yet. So I think that's kind of the next step, and that's kind of where I'm trying to lead my research so that we can do that.
Cool, thank you.
Yep.
In one of your initial slides, you talked about dorsiflexion and how that protects like the ankle joint.
Mm-hmm.
Would that work as well, like on ground contact? So let's say like if someone landed their foot on ground contact in like a planar, like mostly dorsiflex versus a strictly planar flex, do you think that would have an impact on like ankle sprains versus in like cutting or like even sprinting?
I think it could. I mean, if you're always landing in a planar flex position, that's going to lead you more to want to sprain your ankle than if you're landing in more of a dorsiflex position, if that makes sense.
It does.
Yeah.
And then I have another question.
Yeah.
Do you ever see like compensations with ankle sprains, like through the hips and the knees, and then like those cause different like arrays of problems to address?
Mm-hmm. So there's different strategies that you can use if you're lacking dorsiflexion. So there's a couple of different ones. You can hyperextend at the knee in order to clear it, because you have to have a certain amount of dorsiflexion range of motion in order to clear, right, when you're walking. So if you can't get that full dorsiflexion, maybe you only come to here, you still have to advance somehow. So you can pronate or supinate your foot. You can hyperextend at the knee as well as at your hip. And then you can also go into some valgus and varus at the knee to try to still go forward, if that makes sense. So a lot of times that'll end up causing other issues at other joints, all coming from you just not having enough dorsiflexion, which is easy to fix. So, you know, it's something that you can address and fix everything in one little swoop.
What type of braces do you use typically?
We use the ASO lace-ups here at Weber. So, I mean, they're pretty easy to find. I prefer those to active ankles. It just seems to be a little more supportive and a little more protective. And the athletes seem to be, other than soccer does not like wearing them because their cleats are so small. It doesn't really fit into their cleats. So that's the only issue that we really come up with. All the other sports, once they break them in for like a week, they're happy with their braces.
What about your thoughts on the rigid braces that are almost like a cast on the side of them that I typically see in volleyball?
Like active ankles?
I don't know if that's the name of them or not, but it's literally like almost those cast type.
Well, my problem with active ankles is they only limit excessive inversion and eversion, and it's really just on the side. So it seems like you can still kind of go into inversion anyway with those on. We've had our volleyball players have been wearing the ASOs for the last 3 years, and we've had maybe 2 or 3 ankle sprains over the last 3 years. So, I mean, that's a pretty good number. And a couple of them weren't wearing braces when it happened, so you can't really count those.
All right.